Hi, everyone, and welcome to our seventh intergenerational meeting between senior, or with more youth accumulated health educators and medical students who are interested in psychiatry. As you know, these intergenerational meetings are done in collaboration with the PMPC section of the World Psychiatric Association, and it's a series that is focused on creating this connection between people that have experience working in psychiatry and medical students who are thinking about psychiatry as a potential career pathway. And it's a chance to meet and to share experiences and to share knowledge and to learn. And both, I would say, both sides of the table learn as much from each other as we can in each conversation. This particular meeting, we are very lucky to have three great presenters: Dr. Eugene Ko, Dr. Yassima Jamir, and Joyce Guo. The topic of today is cultural diversity in psychiatry. It is a big topic. There is a lot that could be said about this. There are various angles that we could cover. Unfortunately, we won't be able to do justice to the broadness of the topic, but we're gonna start a conversation anyways. And for those of you who are watching these live, please feel free to add your questions on YouTube, and we're going to try to answer them. For those of you who are watching this as a recorded video, thank you very much, first of all. It's our honor. And yes, you can get in touch with us easily and send us an email if you want about, and to ask some questions about each presentation. So I was thinking we could perhaps start first with Dr. Eugene Ko, and then have room for some burning questions. Then we move to Dr. Yassima's presentation, and again, some room for some burning questions, and then Joyce, and some room for burning questions, and then we can have an overall discussion afterwards. So let me first introduce you to Dr. Eugene Ko. He is a psychiatrist, he is a medical lecturer, and an ACT practitioner. And the topic of his presentation is going to be magic in psychiatry. Please.
All right. Thank you, Rodrigo, for that very kind introduction. I'm just going to start up my slides here. And some of you might wonder why with that particular title. So I'm going to just put some context into place first. I'm from Malaysia. We live in a country where we consist of multiple different races, cultures, and it's a big blend where all different cultures actually blend among each other. And as a result of that, as a psychiatrist within this country, I would always need to consider and be very well aware the differences in different culture and how they actually manifest themselves when they come and see me. So I wanted to illustrate that in today's talk, since we were talking about culture in psychiatry, and I decided to use one of the example where a single statement, where a single story, where a single presentation can manifest itself in different approaches. So I'm going to start by describing this idea. So santau is actually a local word. It's a Malay word in origin, but it's a very culturally appropriate word that pretty much people, especially from the northern region of Malaysia, use it in their everyday language. It's actually a very normal term that could be used in the day-to-day sentences. What it actually means it doesn't translate very well into English, But the closest explanation, if you look at the paper from Haig in 2005, it's described as a black magic that is applied to someone by another person, either by putting it into the food or by evoking the presence of jinn or Satan. And this definition do vary, but the black magic idea is consistent throughout. People do it for various reasons. They could do it for revenge, they could do it for envy, they do it for gains, and so on and so forth. There's many, many reasons why someone would do it. And when someone is believed to have experienced Santao, they would proceed to seek help. They would proceed to seek help from spiritual practitioners, of which we call them Bomo or Pawang. And this Bomo or Pawang comes in 3 different flavors, if you may. They could either be very religious based, where they will use religious texts or religious teachings to kind of counter the black magic, or they could use magic to counter the black magic, or they could even be using herbs and spices and different kinds of food-related products to counter the black magic. It comes in various forms, and it depends on the region, depends on the individual, depends on who you speak to. They kind of varies in small details, but they all lump it together with this idea of Santao. And whenever someone comes and say, I have received Santao, I've been cursed by Santao, you pretty much know this person is referring about black magic. Someone has applied it on, and he or she might have gone to seek a spiritual healer or spiritual person to kind of get help for it. So I'm going to talk about one case. And actually, I'm going to talk about 3 cases with the same exact presentation. 3 different cases with the same exact presentation. I'm going to tell you how they present to me. However, because I need to protect the anonymity of my clients, I have adjusted some of the facts here to make sure that it's not actually been known, but the changes doesn't impact the underlying educational purposes, and the underlying gist or the underlying story is the same. All right. So I have a 35 years old Malay ethnicity lady. She works as a teacher. She has 2 children. She's married. And she came to me presenting with 3 months of poor focus, low mood, early intermittent insomnia, multiple episodes of panic attack. This sentence is very classical psychiatry presentations. I believe all medical students, all psychiatrists, all doctors would present this way. We are all trained to elicit the symptoms. And this is what she presented to me in my clinic. The symptoms has caused her to have problems in her marriage and also the productivity at work. And interestingly, she says she actually cannot enter her workplace, the school, due to an unseen force blocking her. And this was the conversation we had during the clinic the first time. Doctor, I've been Santao by another lady. I've seen the packets lying around my house. They usually, when someone gets Santao, they believe that they can find things like cloth wraps around ginger or mannequins or hair or small packets that's lying around. So I've seen the packets lying around. I'm very sure I've been Santao by another lady. I've gone to see the Bomo and I've received treatment, but the Santao persists. There is a mystical being preventing me from entering the school, and I'm only coming to see you because the school insists I come and see you or I'll lose my job. All right. To highlight to you all what I've just described, a classical case here, and this particular conversation was presented to me by 3 separate ladies at 3 different times. The presentation is exactly more or less the same. The story is more or less the same also. All right. Classically, if we look at that, we will start thinking, okay, we're looking at someone who has depressed, someone who has anxiety, if you look at it from the lens of classical DSM-5. And that's true. If we look at it from this one particular lens, the symptoms that she described is not Santao. If we follow our textbook, it is a classical major depressive disorder. It is a classical panic attack, maybe even panic disorders with depressive symptoms. If we look through that lens, however, considering that mental health literacy here is, I wouldn't say it's poor, but it might not be as outraged or as acceptable. Those are the words that someone would not present to me in my clinic. They're not going to come and tell me, doctor, I'm depressed. Doctor, I'm having anxiety problem. They're going to use the words that they're familiar with and say, doctor, I've been Santao. On top of that, if they were to go out to the society and they say, I'm currently depressed, I'm having depression, I'm having anxiety, stigma is going to come into play. Their performance at school might even be affected. But if you go to the school and say, I'm being santao, because it's a society norm, it's a cultural norm, it's actually very acceptable. They could go around saying that without being stigmatized, and it would not incur costs or consequences to their life. That language and culture plays an important role and allows them to carry on with their life while experiencing a very real psychiatric condition, a very real symptom. This is case number one. Case number two, let's add on a twist. Turns out the husband was actually having an affair. This is case number two. And the client, finding out the affair, had a psychological response to it, which presents with pretty much the standard symptoms that we associate with depression and anxiety. However, culturally, in this local setting, it's very inappropriate for someone to create a sin. It's very inappropriate to create drama. And because of that, they cannot go around saying, you're having an affair, you're wrong. They cannot blame and all these things. And therefore, by utilizing the idea of santao, the lady that my husband is having an affair with has santao me. It becomes in a way, a adaptive coping skill or adaptive attention-seeking skill that is both acceptable and appropriate. She can go around saying my husband is having an affair without creating a sin, and at the same time becomes a culturally appropriate term. That lady has cast black magic on my family. It's that lady's fault. It's not my husband's fault. My family is okay. And thus explaining both the psychological reaction that she has and at the same time allowed her to have a very appropriate means to mediate throughout this crisis, to keep the relationship, to keep the marriage by avoiding the blame on the husband. In fact, they put it instead on something mystical that everyone would say, yes, that is correct. That it's a black magic. It's not the husband's fault. And allowing them to figure out a way to do it. It also would allow her, again, back to what we said earlier, to describe some of the feelings, some of the experiences she talked about in a very appropriate and acceptable way. And this is the third case that came in. I got santao. We initially thought it was depressive anxiety. As we talked about it, she started telling me that mystical being is an actual animal. It's a lizard, a very big lizard that I could see, I could hear, and it started chasing me. I cannot go in. And then we started exploring more and more. It turns out the santao was started having, it actually has delusional properties to it. It was a very, very strong belief. It was not just about santao. It was a very strong belief that people were out to harm this lady. It was actually, in truth, a delusion of persecution. And when we explore more over multiple interviews, by the way, not a single interview, over multiple interviews. When we start looking at the story of her being santao, exploring more and more, we started picking up symptoms that fulfill a schizophrenia. Turns out that this person was actually having schizophrenia, the third case. And the other symptoms, the anxiety and depressive symptoms she talked about earlier, was actually a comorbid secondary to the psychosis she was experiencing. And this becomes interesting then, because these three different ladies presented to us in three similar manners, saying of the same thing. I got santao, and I got that same set of symptoms. Depending on someone's exposure, depending on someone's idea or exploration, we could easily mistaken this as a normal psychological experience, or a depressive anxiety, or even as psychosis. All that could be missed if we don't explore and we don't look or understand the meaning behind santao and its context. And this is where I want to raise a few questions. By sharing those three cases, I want to point out to the audience, the students, the doctors who are listening in that there are a few things we need to consider then. Number one, as I mentioned, santao generally involve spiritual and religious intervention. And this lady specifically told me, I only come and see you because my school told me I've already received treatment. I don't need your treatment. This is actually a very common statement being said to me. So is the presence of spiritual and religious intervention an absolute contraindications with our understanding of psychiatry? This is the first question I want to get you all to kind of think about. For my context, for my own practice, no. In fact, we encourage them. As long as the intervention doesn't involve powder, unidentified powders, because sometimes we worry they put in steroids. As long as it doesn't involve unidentifiable food products, usually we say, go on with those interventions, but since you're already receiving that, maybe we could kind of assist you with some of our own intervention, our own therapy, our own medication. We use it side by side. Let's see what happens if we use it side by side. I'm not going to downput to say that intervention is useless. I'm not going to downput that intervention is hogwash, because to them, remember, from a language, from an experience perspective, it's very real to them. They believe in it. It's very acceptable in from a society context. If I were to downplay them, if I were to remove them and call it out and all this, I'm going to cause more roadblocks for myself in terms of the therapeutic alliance I could have with the client. Second idea I want to share with those three cases is the impact of stigma. Remember, in psychiatry, at the end of the day, we always persistently talk about stigma and stigma and stigma. But stigma itself manifests from many, many ways, not just the classical, someone do some discriminatory behaviors to you towards so on and so forth. It could just be because the fear of stigma is so big, people would find a more cultural and society acceptable approach to talk about psychiatric conditions that they are experiencing. Like in this case, you start out to talk about it. And we need to be well aware of this impact of the stigma in order to be able to provide better services, to provide better interventions. How is that going to impact? And we need to highlight to them. And the last one is our students or any psychiatry trainings or doctors, in fact, receiving appropriate training when it comes to cultural and society norms. Do we get that in our own education? We do mention briefly in our definition of delusions, aside from culturally acceptable norms and this, that's the closest I can recall in our textbook that mention cultural. But in our day-to-day practice, do we get this kind of training? Among my student interactions, I might talk about it, but we don't have, it's not formally and it's not a big part. And I believe that this question should be raised because in the future, because it is going to impact how we are when we become a doctor. It is going to impact how we look at psychiatry itself. And the second part, which I think Dr. Just is going to address, is what about students from a different society then? What happens as me, who's trained in, well-versed with cultures from Malaysia, what happens when I go to another country? Or what happens when a student from another country comes to my country and train? Am I going to train them in my culture? Are they going to get the same training with their own respective country when they go back there? Where are they going to find this kind of training or this exposure? I do think that this is something we need to address. This is something we need to start thinking about because it does impact. It does impact the way we interact. It does impact the way we manage, and it does impact the perspective we see what some of the things present to us. So very briefly, quickly, key points, experience and reactions that we have psychologically or otherwise is shaped very much by culture and society. Language does play a very big role. We do need to catch the nuances of this language when people talk about it. There is an element of shared decision-making and not to downplay anything that has been brought to us, but instead work along with the shared decision-making so that management and treatment can be improved. And also last but not least, as I highlighted earlier, being aware of the impact of culture and society norms. All right, that would be end for my very, very quick presentation. And I'll leave back to Rodrigo.
Thank you very much. Very, very interesting. I want to open the mic for the room, but just before doing that, I want to share, it resonates a lot with something I have experienced in Paraguay as well, which is my country of origin. People the term there is paye, but it's the exact same logic. You have been cursed. Someone has done some, it could be benign magic though as well, but most often it's with ill intentions, and you have been put on a curse. And the manifestations are as broad as you have suggested. It can go from depression, anxiety, overall to potentially psychosis, conversion disorder, etc. so yeah, it resonated a lot with something I have seen clinically as well. But like I said at the beginning, we have time for a couple of questions. Does anybody have a question? Idil, yes, please.
Thank you, Rodrigo. Dr. Eugene, I really appreciated your presentation, especially I actually recently read this book called The Night Tiger, which is actually written by a Malaysian writer of Chinese descent, and actually mentions the cultural phenomena that you have shared with us. And I would actually highly recommend it because it has a double narration style. It switches between first person and third person. And it really portrays well how the cultural paradigm the characters are in actually impacts the psychological aspect of the experiences they're having. I wanted to ask about, I think what was most striking for me was the first case and the third case, because they both, like all of them came with the same cultural phenomena, like expressing that. But the first case was actually a case of depression, anxiety, versus the third case was actually like the person was actually having psychotic symptoms and delusions in the clinical sense. So and you said extensive interviewing was necessary to actually identify that. I was actually wondering, since cultural relativity is a rather important point in understanding whether this person is actually suffering from delusions, or like beliefs can be considered as delusions. Is interviewing like the close social circle of that patient, such as the family members or colleagues, was this a helpful aspect of you reaching out to this patient? Is this something that we can utilize in this sense?
For the third case, in fact, we got confirmation when we finally was able to get hold of the family members. That was when it became very clear. But it's not always the case, because again, this is a very acceptable term used by normal society. So the caregivers or spouses, the partners, even the children, all this, could be using the very same term, or this, in this case, Santao, to describe the same phenomenon and believing in it. Because again, this was something they were brought up with. This was something they were taught with. They were not taught like what is delusion, what is hallucination. They might know the brief meaning of it, but they wouldn't be able to relate it with mental the things that we look in mental health literacy. So they will probably just tell, yes, doctor, I do think my spouse is actually experiencing Santao. I do agree with it. That's why we brought her to see the spiritual healers, so on and so forth. So it does have a role. Not all the time, again, because of the way it kind of interacts in terms of social terms. Yeah. Interestingly, I'm going to guess the book you talk about, they were talking about Saka also, S-A-K-A. Did they mention something like that, since there's a mention of tiger? It's actually another term that kind of closely related with Santao. I didn't bring it up here to create more confusion, but that is also another one very common term. A lot of our clients will start saying, I've been possessed by magical powers. They use a word called Saka. And I think that was one of the things that they might mention in their book, seeing the tiger that pops up in my head. All right, I hope that kind of answers your earlier questions.
Yeah, thank you.
Dr. Bullitt.
Well, thank you, Eugene. As Rodrigo said, what you have told resonates with similar conditions in Turkey as well, and which wouldn't surprise any of us, I believe. I would like to ask you this question: what if some people around that person do not believe what she is doing, or maybe accusing her, or because the cases are ladies in this case, being playing, gaming? What happens then? Thank you.
I'm not sure. I'm not sure, because it's in a way the reverse that it's culturally inappropriate to say that someone is lying about Santao. So for someone to actually say that this person is lying, doesn't have black magic, the few scenarios I can think of, I've not encountered myself, but the few scenarios I can think of is maybe someone who's either not familiar with the culture, or who were have experiences in different cultures, or maybe more Western-like cultures, or they have the way they look at this, they don't hold on so strongly to it, and they might accuse it. But I'm not sure what will happen. I do think that because the way of how it becomes a society and culturally acceptable term, to go against it might actually end up causing friction, might actually end up causing more stigma, not to the lady, but to the person saying that this person is lying. So maybe it would not be the best interest for someone to actually even say that. Or even if they do say, they might say it in a very harsh tone. So like that third case, the husband was they believe strongly in this. And even when we point out that, look, you have, this is psychosis, this is hallucination, delusions, he agrees. He agrees to the definition of hallucination and delusion. The husband agrees. But he still hold on strongly to, yeah, there could be an element of Santa also. We're still going to continue seeing the spiritual healer. So they kind of, I think we will create a lot of dissonance to actually force them to say that this is not true. And I'm actually not sure. I do think that's an interesting question. What happens when someone accuses something like that? And it's worthwhile to consider. But personally, I've not experienced, so I would not dare to give too much opinion on what would happen when they do that.
The reason I ask that question is in Turkey, there is a developing or changing cultural situation very rapidly. I mean, some people may have their beliefs continue, but others at least would say, she is doing this. Can I consider in Malaysia the situation is more homogeneous?
I would say that they kind of coexist. As you were saying that, I recall a conversation I had with actually my own wife. I had this conversation, and I remember that conversation again. It was about this someone being black magic and cursed. In that same conversation, we were saying that how it could be possible that this person was cursed, and at the same time, this person, me being a psychiatrist, has a psychiatric condition, but we don't outright disagree with the existence of both coexisting at the same time. And that conversation kind of reminded me that, yes, while we might be more progressive, we start thinking about things from this particular perception or perspective, we don't consciously or intentionally go and challenge it. We just let it be as a parallel kind of beliefs. I do agree with you. As more and more of this exposure, as more and more of this culture spread across the world, we might see changes. We might see it shifting towards what you described just now. But it hasn't reached Malaysia, not at this point of time. And I think it might be years to come before it might happen or might not even happen.
Thank you. I will overuse my powers as moderator. But this is also considering the fact that you might not be able to join us for the whole meeting. And I just want to ask you something, and this is again me drawing from the experience that I had back in Paraguay practicing. A discussion was often about how a complaint from the medical side was, why do people keep going to the healer, to the spiritual healer or the naturalistic healer when things continue to go wrong, or when things started to go wrong, instead of coming straight to us? And the easiest response that we gave ourselves was because the healer is so much more responsive to the person's needs, to the person's perspective, to the person's view. It's much more holistic in their approach, much less, very often they won't put them down, or their beliefs won't be put down in like, this is silly, this doesn't make sense, why didn't you come? The complete opposite, it would be a full embrace of the situation that the person is going through, and the intervention would address it fully again and holistically, which is something we would be missing on our side when in a more sterile environment, we're trying to dissect things and pick up symptoms and create this diagnosis, and there is often a mismatch there. It's something similar in Malaysia.
I think there definitely will be an element of that. But I would gravitate towards more of the idea of stigma. Someone can go to work, someone can go to school and says, I've received spiritual healing for whatever I experienced. Nobody's going to bat an eye. Nobody's going to think twice. Everybody's going to be okay with it. In that same scenario, I've gone to see a psychiatrist. They, like it or not, people are going to pause. The acceptance of mental health conditions, while we have a push for it, we do have advocates about it and all this. It's still not to that level yet. It's still not a normal conversation we can have day to day without people really pause. And I do still see it. I don't think this is a rural, urban kind of thing or education or anything. I just think as a general from the society, that is still there. And that is why that is still one of the major factors why people gravitate towards spiritual or traditional healers more, at least within the Malaysia context. The good thing is we are moving away from it in the sense that it can exist side by side in most situations now. I am hearing less and less cases where it's a versus kind of context. So the traditional healer will say, don't go and see a psychiatrist, stop the medication, or vice versa. That has reduced significantly from when I first joined psychiatry. I don't hear that as much now. It has become a parallel kind of thing. And I think moving forward also, we might not even move away from it. I do hope to see stigma drop, but I don't think we're going to move away from this parallel perspective in any time soon.
Okay. Perfect. Thank you. Thank you very much. Let me now welcome Dr. Jazz for her presentation. She's a psychiatrist as well, and the title of her presentation is The Global Nation and the Psych.
Thank you very much, Rodrigo. Let's see if I can you see this, yeah?
Yeah.
Yeah, okay. So thank you very much, Eugene, for the presentation earlier, because there's a lot of overlap of what I'm going to be talking today. So thank you for paving the way. Just to say, today, I'm not going to touch too much, but what I'm going to do, I'm also going to talk about 3 different cases. Just to give a bit of context, I am a Malaysian as well. I went to medical school with Eugene, and I've moved to Ireland in 2014. So I've been practicing psychiatry in Ireland since then, but practiced psychiatry in Malaysia for 2 years prior to that. So there's a lot of exposure in different ways. And so today I'm just going to bring that up a bit. And the thing is, it's not too much about what we can do or what we can't do, but maybe about giving some perspective on, or being a bit more aware of how culture does play a role in mental health. And even, is there a need for us to go parallel? Like, do we need to go different ways? Does it have to be only the psychiatric way, or can we amalgamate everyone to kind of work together in a holistic way? So that would be my idea of what I'd like to speak about today. So culture and mental health. The idea about how when we do meet people, different people, we can make a culture very homogeneous, but at the same time, it's very different individually. So see, for example, how Eugene was talking about Santau earlier. It can be also perceived differently on how the impact of Santau, for example, can be on a person, and how that then is being taken on, onto someone's mental health, and how then will they be triggered to become ill out of that, or can they manage it and all that. It's still very individual. So when we think about the role culture plays in mental health, the prevalence of disorders as well, which is quite interesting. So how you can see in different cultures, how some may have more of maybe a psychotic type display, maybe in some places more dissociative type disorders, or even depression, anxiety, how they're being expressed. So different expressions in different cultures and their understanding of what's going on, and their idea of approach of treatment, what works really. And that comes back to the whole discussion about stigma, because do they even have faith in the power of medication being the way to go, or psychotherapy, or is it still taking special herbs, or all these different things. So it's very important, I think, for us as medics to get into that zone with patients when we see them, for us to understand what their narrative is, what their world is like. And once we get into that, then we can sort of work together hand in hand with them to get that trust and therapeutic alliance as well. So generally, when we speak about psychiatry, psychiatric illness, we speak about the abnormal, what is out of the norm. But when we think about it, it's quite subjective, that one. What is abnormal? Something that's quite common in one place is totally out of whack in another place. So then is someone mentally ill just because they're in a different place? So it's again the context which we need to, it's the richness of that we need to understand a bit more. So how I would suggest is to look at it from 3 different angles when it comes to culture. Cultural syndromes would be syndromes where a specific list of symptoms that we see in a specific group in different cultures. The cultural idioms of distress, idioms being the language, so how they express their distress. And sometimes, especially if we talk about conversion disorders, dissociative disorders, and all this, functional disorders, it's a lot about the somatic language. And then they'll be like, oh, I'm not stressed, it's just my body doing all these things. But so we need to understand that part of it. And cultural explanations of distress. So how do they perceive what the cause of it? So say, for example, how Eugene was saying earlier about Santau, it's an external thing that's doing that to me. And somehow it's a bit more accepted in that culture. And then in some other culture, oh God, I don't know what you're talking about. How can this thing ever do this to you? You're mad, you're deluded. So again, it's not about how Rodrigo, you were saying earlier as well, it's about embracing that together and respecting the person's story. Because I think when you feel dismissed, that's when you lose the person and you can't really help them. So first case, very quickly. So I met this man, he's from Peru. He's been living in Ireland for quite a while. He's a 33-year-old man from Peru. He's separated from his wife and he's a father of 3 children. Now he came to to Ireland, I think about 16 years ago. And he had presented to his GP with a 6-month history of feeling very hopeless, having death wish, not suicidal intent or anything like that, but just wishing that he could just go. Reduced function. He was not working as well anymore. He was socially isolated. He was showing biological symptoms as well of insomnia, poor concentration, weight loss. So he went to his GP. GP felt like, okay, this guy seems to be a bit depressed. He did say that the trigger was because he had not been able to see his 3 children over almost a year. His wife is a local woman. And according to him, because I was only getting the narrative from him, he was suggesting that the wife had been quite spiteful towards him, and so is using the children against him, and has brought it to the court saying that, he's from Peru, he wasn't working at the time, so he had no access to the children. So this was causing lots of stress for him. He was not able to see the children. And so the GP gave him sertraline, antidepressants, and also suggested maybe, refer him to a counselor, have some talk therapy and see where we go with that. This did not improve, so which is why he referred to us in the mental health service. And by the time I saw him, interestingly, he had told me that he was feeling a bit better. He wasn't having those symptoms anymore. And according to him, he had been going to a spiritual guide, a shaman that he found. So interestingly, there is I don't know if people are familiar with the Ayahuasca plant, which is quite common in the Amazonian South American region to be used as a medicinal plant. And because he's Peruvian, so he would be quite familiar with this use. Now, he did not come from a background of using it, but because nothing really was working for him, he didn't find the counseling too helpful. And the medication wasn't doing too much, he says, so he stopped. So he said, you know what, why not give it a shot? So he went for this. So there is actually a place in Dublin, in County Meath, where they actually have a retreat of ayahuasca practice and shamanism and things. So he went there, he started doing that. And the whole point of this, just for those who don't know, ayahuasca is a plant which is hallucinogenic. It's a psychedelic as well. So it makes you get into a different state of consciousness. And he was practicing astral projection. Again, if we don't know too much about this, we can talk about it a bit later. But the idea is to get into a different plane of consciousness. And he believes in that practice that he was doing, he was able to connect with his children that he was really missing. And he did truly believe, so he was convinced with this, that he was actually connecting with the children. And it's not only on his side, his children are also benefiting from it. He's playing with them in the garden or something that he meets them at, and when he sleeps in their dreams he tends to see them. And I think at one encounter he did speak to his son, and his son mentioned to him that, oh dad, I dreamt of you, you know. So that even made him more convinced, and he said, you know what, this thing is working for me, I'm actually very happy, I'm feeling very good, I don't think I need to see you anymore. So which is great, because in my clinic I was like, great, I didn't have to do anything to this guy, you know, he has found his form of healing. It wasn't a psychiatric mode. If at all, sertraline was tried on him and he didn't feel any benefit from it. The technical, method of treatment of then referring him to a counselor, he couldn't but he found his connection and he found solace in that. So that was interesting, I thought. So this is one guy. And then the next case I have is a man from Pakistan. Again, he's in Ireland as well. So all these cases I would have seen while I worked in Ireland. He's a 43-year-old man from originally from Pakistan. He's single and he's the only son from a family of 7. Now, he presented the emergency department at the time with a 5-month history of depressive symptoms. He believed that he was casted by black magic, and he was also showing sympathetic hyperarousal symptoms. So we'll get into that in a bit. But this was really impacting his ability to function, and he was just not doing very well. So he came into the hospital. Interestingly, when he came to my emergency department, to the hospital where I was working in, it was his second visit. So his first visit was about 2 weeks prior to that in a different hospital. And at that time, I'm not too sure if people are familiar with the catchment area type concept where mental health is treated in, based on your address. So his address was from my hospital. So he went to the other hospital first. And so they had referred him to us, and then he presented, and at that time he was seen by an Irish person who probably understood the DSM type language and said that, oh, okay, this guy's got delusional disorder, he's psychotic, he needs potentially admission, but at the moment he needs antipsychotic. So that was the story I got from them. Exploring a bit more with this guy, interestingly, he reported to me first when I went in, he assumed I was from Pakistan because of the way I dress and the way I look. So he was like, oh, okay, for once I can meet someone who understands my story. So what I thought was interesting was the fact that he assumed I understood. So that also plays a role, I think, is when someone feels the potential confidence of being understood and being heard, that is one step forward. I did not break the news that I'm not from Pakistan, and I may not fully understand what he's on about, but I did take advantage of the fact that he had that trust already, and he opened up, more to the story he had. So just a brief context about this guy. He's 43 now. At the age of 30, he had moved to Germany. At that time, there were lots of financial pressure and also marital stress at home. Not marital, as he's not married, but there's a lot of pressure because from the specific culture that he comes from, being 30 was old. You have to be married. And so there was a lot of talk already where the culture was, or people around were talking, was there someone who had the evil eye or I think the evil eye being casted on you. And maybe that's why you're finding it difficult to find someone to get married. And then now the family's going through a lot of financial difficulties. So, you're the only son, you should go out there and get, support and all these things. Anyway, so that's how he moved to Germany. He did some odd jobs. He was able to, feed the family a bit at home, not too great. And then he had some friends who were going to England to start up a business. So he thought, okay. So at the age of 34, he went to England. He opened up a phone shop. Soon after that, he said a competitor came along. So pretty much another guy then came up and opened up another phone shop close to his. There was a bit of competition. His business got affected. Again, when he was telling me the story, again, there was a lot of there's someone meaning ill towards me, and the person wanted my business to go off, you know. So he couldn't see it in a way that, oh, maybe coincidentally this person came along, maybe his technique wasn't great, you know. He couldn't see it that way. So again, if people are for medical students especially, maybe if you want to look into what we call external versus internal locus of influence or control, right? So where in this case he believed that the outside, there was a force from outside that was affecting the consequence of life and what was happening with him. So anyway, he was a bit upset with that. So eventually he moved to Ireland at the age of 39. So this was about 4 years ago. Again, he opened up a shop, and a similar thing happened. He did pretty well. According to him, he was doing quite well. And then a competitor opened up some stall close to him. Unfortunately, this competitor happened to be from Punjab, which is from India, which is close to where he comes from. So this strengthened his conviction that this person then had put black magic on him, because he comes from a similar culture from where I come from. And I could see little talismans and little things that was around the shop. So I knew that was purposefully directed to me. Yeah. So I can see why this previous doctor thought that was delusional, and it probably is. The level of conviction he had. Again, when we talk about belief, the conviction of 100% of a person who's deluded could still not be a delusion in a different culture. If someone was to say, I believe in God, and that's a full conviction, it could still be a delusion in another culture if they don't believe in it, you know? So we want to see what the story is here. So his cultural explanation from the three things I was saying earlier is that this is external, this is black magic purely. So when we got into conversation, and I was trying to take advantage of the fact that he knew I came from a similar background, I said, okay, maybe this is happening, but clearly this has affected your life, and it's clearly, you know, affecting you in some very negative way. Do you think maybe if we could add on and try different things from what I think I'm trained in, maybe that might help you and we can amalgamate it together, you know? And he wasn't buying it very much. He was just, this is black magic, we need to get rid of it. And his belief in the treatment of it is what it's an Islamic thing. It's called ruqya. So and they do that a lot in Pakistan, especially the background he comes from. Very it's much of a belief that ruqya is the only way. If I do it, then things will go off and I'll get on with life, you know. And then the moment we talked about psychiatric mental health, the type language, stigma was alarming. So at that point, I couldn't sell it to him. And unfortunately, because I saw him in the emergency department, I could just only refer him to the next person. Now, whether he followed up or not is a different thing. So stigma becomes, you know, roadblock when we talk about it. So that's one. And so just to run through very quickly the symptoms he had. So poor sleep, low mood, social isolation, poor appetite, poor self-care. So when we see all these things, we're thinking depressive disorder or severe anxiety, that kind of thing. The conviction we talked about earlier, is this a conviction? Is this an overvalued ideas? How do we put this into context with DSM? His biological symptoms here, I mean, the hyperarousal symptoms, he had hypertension, headaches, chest tightness, lightheadedness. He had amnesic episodes as well. And again, to him, that was the black magic effect. You know, now I'm having a headache, see that thing is doing to me, you know, so it really feeds into the language. And very quickly, my third case. Recently, I saw a 74-year-old man from Ukraine. He's a refugee from the war. So he just landed in Ireland about 3 weeks ago. And he was before a very esteemed director of architecture school or something like this. So he was quite a highly functioning person in his society, had built lots of different buildings and different sculptures around Ukraine, and he happens to be from Kharkov, which is one of the cities which is really badly affected in the war. So it really broke his heart when lots of his work had been destroyed and all these things, you know, plus on top of the war, safety and all this. Now, he presented to us again with a one-day history of acute behavioral change. He was very disorganized, flight of ideas, very incoherent, talking about things, paranoid delusions. His general theme was about fear and feeling unsafe. And his affect was very labile. It was very interesting. He was crying intensely at one stage and suddenly laughing at things. So very incongruent. He was just kind of out of it. So at that time, we were seeing it more of an acute psychotic type thing. It could be transient, acute stress reaction or somewhere along those lines. Now, he had landed in Ireland for 3 weeks. 3 weeks he had been in Ireland. He was living in a safe place and, you know, a good environment and all this. But it was a 1.5 week trip from Ukraine to Ireland. They had to go by on land through Poland and then had to go to Germany. And it was quite a rough situation when they were in Germany, and then they eventually came to Ireland. The son did say that he was a bit more withdrawn. He was very preoccupied with the news, not sleeping very well because he was just constantly checking on the phone and checking on media, what's up at home, crying all the time, very irritable, having paranoid thoughts about different random things, and was always reassurance seeking. Right. So the point of me bringing this up, which is, again, I mean, we can see quite clearly, you know, soon he was admitted into the medical ward initially because he has no psychiatric history. They wanted to see if this is a delirium or something like this. I work in liaison psychiatry. So that's when we started him on antipsychotics. He came out of it after about 5 days. He was much better. Then he was just referred then to the old age psychiatrist to follow up. But my point of bringing this bit up was how I noticed the son, and he was giving me collateral history. It was interesting how he was quite flat. He wasn't flat in a dissociated way, but it was more of his style of talking. So very pragmatic, very matter of fact. Yeah, so this happened. Yeah, and then dad had to do this. Yeah, it was a hard time. And then if there was anything that was difficult to talk about or anything, one of the topics was about his late mother. And he says, I'm not going to talk about that, and just very shut off. So one of the things I realized was one of the advice a consultant gave me a few years ago to say, just notice, again, it's a cultural thing, but people who tend to come from Soviet countries or ex-Soviet countries, whatever way their historical experience and all this, there is a tendency of them to not express distress too much on the face, you know, so they don't, say, compared to someone we see from Greece or Italy or something, very expressive people. And again, it's not wrong or right, it's the way they express themselves. And just to keep in mind that even with the way the son was presenting, which really stood out for me, was how extremely zen he seemed, which is, you know, something I wouldn't be too used to. When the Irish people wouldn't be, expressing that way. So if anyone's interested, you can have a look at this little reference I've put at the bottom of the slide. The topic is called, the article is called A Cross-Cultural Study on Emotion Expression and the Learning of Social Norms. They compare different countries and how they express themselves, which I thought was quite interesting. So that's my little bit. Sorry if with time.
Not at all. Thank you very much. Very interesting presentation as well. And yeah, I'll open the mic to the room if there are any for a couple of burning questions. I don't want to overuse my moderator powers again.
Can I just say something? Yeah, I think that was a wonderful presentation, Dr. Just, and thank you for enlightening us about 3 totally different cultures that I myself have not experienced. I mean, I have not had an encounter with someone from either of those cultures before. But I think it ties quite well with Dr. Eugene's questions earlier. And I would actually like to tie it to the 3rd question that he asked, which is, are medical students getting, or even master students, trainees, psychiatrists, receiving the adequate training in these respective cultures? Because as you have presented, your experience has brought you patients from 3 entirely different cultures, and you yourself are a person who's from another culture itself. So, you know, even yourself migrating to a different country has brought you to cultures that are different from the country that you're currently practicing in. So this got me thinking actually about, like, even the status here in Malaysia, for example. We do have some foreigners who would present to the psychiatric wards, and not just the psychiatric wards, obviously, but should students be taught about their cultures as well? And should students be, like, aware of these things?
Yeah. Yeah, thanks. I mean, that's an important question, but sometimes I do wonder if it has to start from our attitude of how we approach things. I think if we can come in with a mind that we'll never know too much, we will never know everything, we can't be exposed to everything. We're not God like that, you know, but I think when we come in with an open mind of not being too critical, I think what can potentially be at risk is, especially as medics, there's a bit of a God complex that tends to kick in sometimes. We think we know everything just because we studied certain things and I've seen certain things, you know? So it's good to come in with that mind that I think I know my job, I think I know what I'm doing. But knowing that sometimes you learn from the client, you learn from the patient. They bring the bag of information for you. They are the people who are going to teach you what's going on. So if we come in with a paternalistic mindset, I think that's when we can go wrong. But if we come in with the idea that I want to be there to work with you, I am trained in what I do, and with the little information of different cultures I know, yes, but I want you to educate me. And I think with that attitude, when we come in, sometimes actually opens up in our demeanor or our style of talking, it comes out to the patients as well. They feel that openness, they feel that they're going to be accepted. And then we let them tell the story, and then we find the open ground to that. So again, of course, then through the practice of that, like see how Eugene had spoken a bit about Santau, right? And then from me, from these 3 little countries, which is like nothing compared to the ocean of other cultures that we were not exposed to, you know? So yes, as we learn it, we expose it to students, we tell other colleagues to educate people as we go. But I don't think if we are going to be aiming to be teaching as if we're going to reach a certain level, I don't think we're ever going to reach that level. I think we have to come in with that mindset first. I hope that helps with the question.
Yeah, it does. Thank you. We can't learn all the cultures in the world. I mean, you can if you want to, but it's very difficult.
Very ambitious. Yeah.
Ideal?
Thank you, Dr. Rodrigo. Thank you, Dr. Jamir. It was a very interesting presentation, and thank you, Ramir, for your question. I think it's really added up to what I wanted to ask. Like what you said, Dr. Jamir, the attitude and approach that we should have with this sort of understanding that we don't know everything and we should be always be open to learn from the patient. Like Dr. Eugene mentioned about how seeing this cultural phenomena and the psychological part as 2 coexisting things. I think it really opened my eye, and I kind of like listened to your presentation with that sort of eye opening. And like as health providers, people, especially mental health providers, people can come in front of us with their problems stemming from many external factors, as with the patients that you have presented. And you know, when someone can come to us suffering from let's say oppression, or like suffering from war or financial difficulties, we don't claim to be, you know, economic experts or like expert sociologists or expert people in like international law, and like try to sort of come from a point of knowing how their problems actually impact them fully. And we try to understand it through the patient. And perhaps like the same thing can apply with cultural, like problems presenting in a cultural way. And this could be something that we see, and like the help that they're seeking is something that we see not as obstacles, but actually something that goes to the path of healing, because we are actually trying to support them psychologically through the means of psychiatry, and we can actually understand how they're trying to cope culturally. So culture is not just like, it's not an obstacle that we have to like jump over, but it's actually something that people can use to cope with. I just wanted to share that, and I think the things that you have shared has really built up on that. And like the last thing that you mentioned, the mindset we have, it's the most, perhaps it's the thing that we need to focus on teaching medical students and teaching each other, not to be an expert of all cultures, but to have that right attitude, that sort of curiosity and understanding towards that. So yeah, thank you for that.
No problem. And I'm glad you brought that up, Idil, because to me, I think what we need to realize is that individually, we all make meaning out of a circumstance. There is meaning that comes out of it. So 3 people in a similar war situation would take different types of meaning, and that then impacts their mental health in some whatever way. You know, so if we can try to be curious about understanding what the meaning is to them, and what now, what help can I do, what can I be of any help, or can I contribute in some way? And again, I think we disarm the defenses, because with stigma, for example, a lot of times I believe, this is just me thinking, is that stigma comes when there is a lot of attack, that it's my fault, that there's something not right with me, there's something weak about me, or there's something internal again. And when it's harshly accepted, that's when you become defensive. So when you're coming in with the idea of wanting to understand the meaning of what you are saying, you're disarming them, and they'll be open to listening to what you need to say. And then that's how I think things can flow.
Thank you very much. Yeah, it's very ambitious to hope to understand. And the thing is that culture is such an intrinsic part of our being that comes from it's what we're made of, and we are connected to it. It informs our way of looking at the world, and the meaning we make of it, and how we relate with it, and how we talked about it. It's such an intrinsic part of everything, that perhaps a way to think about how to best then acknowledge the fact that I might not be able to see the world as this person is seeing it, or talk about it as this person is talking about it, or share meanings, it's acknowledging that fact, and acknowledging the distance, but that and trying to build a bridge, and being in a position of learning, and ideally, perhaps even if it is possible, to count with the help of. Are there cultural advisors potentially? Are there cultural advisors in the hospital, Dr. Just, that you can go to and ask for advice?
So see, for example, in Ireland, there is a traveler group. It's like they consider it sort of minority now, but it's a traveling type community. And because their style of looking at things is starkly different from maybe the majority of other people around, so we actually have a specific person we contact to speak, because even sometimes the language of even understanding what they need to say, they speak English, but a very different way of talking, right? So they almost come in as an intermediary. So when we are trying to educate, for example, the person comes in between and talks to them, or reaches out to their community. They're quite closed in the sense that they don't trust people very much. So they come in groups, for example. So when they come to the hospital, the whole family comes to the hospital together, because they all have to come together and do things, And then sometimes simple things like, even if it's not psychiatric, but even simple security guys say you can't come in because of COVID or something like this, boom, they all explode, no one's happy, that kind of way. So there is that. So that's one little thing. But there's also little organizations around. So say, for example, we have this thing called Spirazi, which is a support service for refugees from different cultures. So they are always in a process of building up more and more diverse educational pieces. So it's not specifically for psychiatry, but the resource is there. So if at any stage we are not too sure about certain things, or we want to get some advice on how to deal with certain things, there is a point of contact where we can find out a bit more to understand. There's that. It's work in progress, but there's definitely a point of contact that way. Yeah.
Mm-hmm. Mm-hmm. Yeah, and sometimes the health system itself has been built within certain cultural values itself. Yes. That and there might be a whole history of poor relationships between communities that informs also how people relate to institutions and the health system potentially, and things like that. And I also love what you say, and I'm sorry, Joyce, I will just go to you. I also love what you said about there are cultural syndromes, there are cultural idioms of distress. But it is also important to be mindful that even within each culture, there are specificities, and people might not adhere to what we think about the culture as a whole, and there are individualities, of course, like with any place. Thank you very much. I'm mindful of the time. Joyce, the cherry on top of all three presentations. I think it's going to be great to hear about. We have been listening about us as psychiatrists providing care to people that are coming from a different culture than ours. but an important part as well of cultural diversity within psychiatry is cultural diversity within psychiatry formation, and the experience of one coming from a different culture into training in a different culture itself. So it's kind of like looking within at that cultural diversity, and that's exactly what Joyce is going to share with us. Her experience of having grown in one culture, but then having received treatment in a different culture. So Joyce is a 5th-year medical student here at the University of Auckland in New Zealand, and the title of her presentation is Minor but Louder.
Thank you, Dr. Rodrigo. So when I was a kid in China, where I was born, cultural diversity was very much a non-existing concept. Looking around, all of us were Chinese. We speak the same language, eat the same food, and share the same culture and a similar understanding of how the world operates. So when the 13-year-old me moved with my family to New Zealand, it was a drastic shift. I have to speak English on a daily basis and adapt to a completely different culture. What made it even more confusing was that New Zealand is a highly culturally diverse country, especially in Auckland, the largest city in New Zealand and where I live. In Auckland, around 55% of the population are European. Some have been in New Zealand for generations, and some are also immigrants. About 10% are Maori, our indigenous population. 15% are people from Pacific Islands, and almost 30% are Asian, mainly Chinese, Indian, and Southeast Asian. The remaining 5% are people of other ethnicities. These ethnicities are not mutually exclusive, with many people identifying themselves with more than one ethnicity. So it was confusing because it is no longer learned and applied to everyone's situation. It wasn't easy to know what was appropriate to and expected of different people and how I should interact with them. So fast forward to now, I'm a 5th-year medical student at the University of Auckland. This is my 2nd year on clinical placement, rotating around different specialties. New challenges have emerged as I'm trying to learn how to navigate different types of relationships in the workplace, relationships with colleagues, supervisors, and the patients. The most challenging thing I found was learning to interact with authorities. So basically the rest of my team, since I'm just a medical student. In Asian culture, we value humbleness as a virtue. We show great respect to people who are older than us and who are in higher position than us. People with authority are untouchable, powerful, and can be scary. We are not expected to speak to them when we are not spoken to, let alone have a casual everyday conversation with them. So maybe I am exaggerating, and I definitely cannot represent everyone from China or Asia, but that was my impression I had because of my background. Along with being an introvert and tending to be a listener in group setting, I was very quiet during ward rounds and when we were having coffee or lunch together as a team. It was scary to ask them questions, so I tend to just search them up in my own time. I was constantly anxious because I was so afraid to say something stupid, so I kept my words to the minimum, which I suppose also made them less keen to talk to me. It was stressful and I was always overly alert. But luckily, one of my supervisors noticed my abnormality and gave me the feedback that was life-changing. He had a sit-down conversation with me and pointed out that I was too quiet. Although I showed good clinical knowledge when I present the patient I clothed, being quiet can be seen as not confident or not competent in Western culture. He kindly warned me because he was also a quiet person and was disadvantaged by it in his career. He said he is from Sri Lanka, so he understood me because Asian culture value humbleness as a virtue. But in Western culture, people prefer confidence. So after his feedback, I put a lot of effort into speaking up more in teams. It was not easy because I was directly testing my fears by speaking up and showing more of my true color. It is all new to me to be proactive, initiate discussion, and showcase my leadership in front of people who are in higher position than me. I'm still constantly improving, but now I feel more relaxed in the hospital. Now, no one would say I'm too quiet, and they give me nice feedbacks as being very involved and ask good questions. Studying and training in a culture different from where one grew up is challenging. But to us, it is an inevitable lesson to learn, so we can fit in and thrive in a new environment. After all, we are the minority. We can't change the social expectation overnight, and we need to be louder to be seen. On the other hand, studying and training in a culture different from where one grew up has unmatchable advantages. Don't forget people of your kind, because you are a treasure to them. As a medical student who grew up in China, I was able to translate for the team and build better rapport with Chinese patients. In Auckland, 10% of the population are Chinese. A significant group of us are first-generation immigrants, and many of our elderly parents who are in their 60s and above can barely speak English. My teams were always so grateful that I could translate when a former interpreter was unavailable. Additionally, I was able to relate better to Chinese patients. I could understand the struggle of a depressed, suicidal Chinese teenager because they have the typical Asian immigrant family dynamic. The over-controlling parents with extremely high expectation for their children. It was easier for the Chinese patient to communicate with me because we share a more similar culture and worldview. We don't need extra explanation to understand each other. They tend to reveal more information, such as the use of traditional Chinese medicine, alternative practice such as acupuncture and cupping, and more of their concerns. It is therapeutic for them to speak in their mother tongue and have someone who can understand them better. It also made my day whenever I got to speak Chinese to my patient and build a great relationship with them. On that note, as a medical student of an ethnic minority in Western society, I really support the promotion of cultural diversity in healthcare providers. This will lead to a better understanding of the ethnic minorities, encourage their access to healthcare, and ultimately improve their health outcomes. Psychiatry has a big socio-psychological aspect, and a person's cultural background plays an important role in formulation and management. Hence, it is more vital to have enough representatives of ethnic minorities in psychiatry. So looking at the New Zealand data, almost 70% of New Zealand psychiatrists are European, and 70% of all doctors are European, which matches well with the 70% of the general population being European. 5.8% of New Zealand psychiatrists are Chinese, which also matches well with 5.3% of New Zealanders being Chinese. But only 2.5% of our psychiatrists are Chinese. I have had multiple Chinese people working in the mental health sector telling me that we are in need of more Chinese psychiatrists. And looking at our indigenous population, 16% of people in New Zealand are Maori, but we only have 3.5% of all doctors being Maori, and only 2.7% of psychiatrists being Maori. It has been well evident that Indigenous people tend to be socially and economically disadvantaged due to colonization. They tend to have worse healthcare access and health outcomes. It is upsetting to see the big mismatch. New Zealand has been trying to increase the number of Maori doctors by reserving space and providing extra support in medical school for Maori students and promoting healthcare careers to Maori children. So being a medical student in a culture different from where I grew up has been challenging, but rewarding. As an ethnic minority in the healthcare sector, we have our own irreplaceable strength, and we are vital in improving health outcomes. As a future healthcare provider, I look forward to speak up for the ethnic minorities and providing a different perspective in various situations. All the data was from the 2018 New Zealand census and the 2018 New Zealand Medical Workforce Report. Thank you for your attention.
Fantastic. Thank you very much, Joyce. Would anybody would like to ask a question? Chance.
Yes. Joyce, that was a beautiful presentation. Thank you so much. I was inspired by what you said, and I think the way you had written the thing as well, the flow of the story, that was beautiful. And the one thing that really hit me was, I almost forgot that's how ancient I feel at this stage. But when I was a medical student too, coming from Malaysia and coming from, again, the culture where you don't speak up very much, or if you ask questions, you look stupid, or you should go find your own, stop asking people all questions all the time, just go find out yourself, you know, that kind of thing. And then the idea of leaving the country at the age of 18 when I came to Ireland to study. And at that stage with trying to figure out the world and all that. So no, I'm not talking about myself too much here, but I could connect to what you were saying, because I remember how our lecturers used to pick the Asian students aside and actually gave us the exact same feedback, saying, you people are a bit too quiet. Your knowledge is awesome, because when you do your exams, your papers are great. You do very well in your thing, but you don't present yourself. And it is a culture in the West, for example, where you would speak up and you would present yourself. And there's nothing wrong with that. Like how I speak now is nothing to what I was when I was a student, for example. Had to force, and the anxiety and thinking a billion times before saying something, you know. So I'm glad you had that experience of coming out and knowing the benefit, as how you said, it's tough enough, but also the benefits of being a minority is how much you can contribute, you know, because there will be a niche and specialized niche that other people can't help cover, but you can. And that's a beautiful experience, I would imagine. So well done.
Thank you. That was very reassuring to hear. Yeah. Mm.
No, please go, and then I'm going to ask my questions. Idil?
Thank you. Joyce, it was a wonderful presentation. It's just, I just want to acknowledge the exposure and the sincerity you put on it, and like the way you combined it with also evidence-based, and with an evidence-based approach at the end. I think it was just like, it stirred emotions in me, but it also stirred like a force of action. So, and my voice is sort of failing me, but I just wanted to tell you this and acknowledge you in front of everyone. And I'm not a minority in my own country, and I was always, not always, but I try to be aware of the privilege that it brings. I did spend a very short portion of my childhood in the US, hence I learned English. And I just want to say what you have experienced as a medical student and the burden that it really has on someone, and the growth that you have showed, and it really is something to be proud of, and it is very relatable, and I'm just really thankful that you shared it and pointed out. And please always be loud, because I think you're very good at it. Thank you.
Thank you, though. That was very kind.
I guess just to echo everybody's feeling, thank you very much for sharing your personal experience with us, and for the people that might be able to watch the video afterwards. Very inspiring, and I'm confident it will resonate with a lot of people, and hopefully those who have not yet seen the bright side of being an ethnic minority in healthcare are going to be able to see that there is definitely this bright side that comes with it. And I can acknowledge as well the burden that might lead someone to feel, the burden of representation, the burden of responsibility. Everything you're doing is practically on behalf of or in the name of. And that can be very, very, very heavy, a very heavy responsibility as well. That unfortunately, even though it might not necessarily have to be the case, there is no way potentially, it's hard to shake it off, I guess. But yeah, it's thank you very much. I came to New Zealand as a 30-something-year-old. It was surprising to me coming from a place where there were so many of us to suddenly become a minority. It was like, but I'm not. There's so many of us, and it shook me a little bit. And it went an extra step when I stopped being a Paraguayan and I became a Latino, which is again something that wasn't familiar to me. I hadn't been a Latino before. I have always been Paraguayan. We are so very different from people in Colombia and Argentina and Brazil, etc. And then all of a sudden we are all the same, practically. And in a way, it was great to be able to look back at home through these lenses and see that, oh my goodness, we are really a region that shares so much in common. It's heartbreaking to know that from within we just see barriers and walls, and from the outside there is so much in common. But again, that I'm diverse, and that it was inspiring, I think, and that's why we have all started to talk about our own experiences, because it resonated and it moved something within. So yes, thank you very much. And I don't want to out you, Idil, but are you considering perhaps to go back to study in the US potentially? Is that something you have in mind?
Yeah, I actually want to do a psychiatry residency in the US. And like I'm in the sort of messy, complicated, intricate path of pursuing it. Hopefully I will have a voice when I go there, and it won't fail me when I need to speak up for myself and my patient, as it's doing right now. Thank you for asking, though.
I'm sure you will. Yeah. But Eugene, do you wanna say something?
Yeah, I do apologize. I my camera off, but Joyce, thank you very much for that sharing earlier. I'm not sure would this help, but I would kind of tell you, even though many years of presenting at international conferences and all this, after so many years, the part that you said of being Asian, especially being Chinese, where the humility and all this, the values that is there, it doesn't quite go away. Even until now, I get anxious whenever I'm required to speak. I feel that no, this is against who I am. There's an element of me that would feel out of place, but it's something that, like you said, we do need to kind of learn and work with it. And I do really appreciate that you speak out something that most of us, don't share commonly.
Thank you.
Thanks, Eugene. Yeah, as you could tell, you have stirred it was, yeah, thank you very much. I guess we don't have a lot of time before having to close the meeting. So are there any questions about any presentation or comments you would like to share? For me, I guess I have recently worked on a piece of a manuscript that was focused on somatization and culture, and I run into cultures, idioms of distress, and what I found was this very commonly held belief that people from Asia and people from Latin America tend to have a higher prevalence of somatization. But looking closer at the studies, they were often conducted in Western countries, we could call them like that, with migrants. So it was the local interpretation of what the Asian or the Latin American individual was bringing to the table. So it was reading something that was brought to the table through a lenses that interpreted it as somatization. But what I also found was that, at least in the case of Latin Americans, which was my focus, very often people won't necessarily prioritize psychological symptoms over somatic symptoms, and it will be an equal complaint of the headache and the distress that you're going through. So depending on what I'm paying more attention to, I might end up in a somatization route of diagnosis and treatment if I don't pay attention to the distress that is also brought to the table and follow that farther. Or I might not even move beyond the somatization and ask, how are things at home, or how are things at work, etc. And this is something that has been even built within our assessment tools, that if one is to follow very strictly an assessment tool that has been validated, etc., and it might lead you towards this route that doesn't represent what the person is bringing to the table, and that's because the assessment tool itself has been developed with a certain cultural lens that is not the same one that the client is bringing to the table, that the patient is bringing to the table. So all of that is just to highlight that being an ethnic minority as well, as we all know, the knowledge production system has favored knowledge being produced in certain parts of the world. And this is knowledge that then goes back to other parts of the world. And to use a word you used, Joyce, it colonizes again these other parts of the world. So having the privilege, perhaps, of being being someone from those underrepresented worldviews in a place where knowledge production is favored, gives us the opportunity to play a part on that as well, and to represent this. First of all, it's easier perhaps for us to notice where there is a mismatch or where something is missing, and then to perhaps help to fill that gap and to help to make the knowledge that everybody's using fuller and more representative and more comprehensive and more inclusive, so that more voices are participating in that global discussion. So that is also a privilege of being from once you move, an ethnic minority in a country that produces a lot of knowledge, so to speak. So yeah, I just want to highlight that as well.
Could I add to that, Rodrigo? That's really interesting, because at the moment, the job I'm working with a professor who is very interested in functional disorders and things like this. So if anyone's interested to look into this book, if you have not already heard of this book by Suzanne O'Sullivan, it's called It's All in Your Head. And it's a very interesting book. It's written by a neurologist. She is a neurologist. And I can't remember how I came across this book. It was suggested by someone, but it's also really interesting, again, with somatization, the meaning that comes from that. And at some stage, people speak about people who have alexithymia, and that's why they present with somatizing symptoms, because they can't read their emotions. But again, as you said, what is reading emotions? Why is there only one way of doing things? And there is a bit of an imperialist colonizing of a certain one knowledge, and that's it, And if we it feels like the world is working towards globalization into one global culture, we are losing the sweetness of diversity, where it actually has its own beauty to have the different bits of it, and I think in the process, there's definitely good, because right now we're on Zoom speaking one language from different parts. So thanks to colonizers, we all can speak English, which is great, so there's always pros and cons. But if we can acknowledge that there is beauty out of diversity and there are things that we can learn from that, then why not? And let's celebrate that and enhance that, because even when I speak to patients, when they're so convinced that they're coming in with pain, for example, and it's traveling all over the body, and I do have interest in psychoanalysis. I think there's a bit more exploration of what it means and all these different things. And again, not denying the problem, but embracing it. Okay, it is a problem right now. How can we speak that language together? I think it's that ultimately it comes back to the therapeutic relationship, isn't it? Because it's that heals sometimes, not the technical knowledge that we have putting in. I digress too, but yeah, look into this book. I find it very helpful, and I think people who, especially in psychiatry, it's something important that we can look into, because I think sometimes we do come in with just one window. It's almost like Johari's window. We think that's the only way to look at it. But there are many, and there is benefit that comes from different lenses.
Absolutely, Dr. Bullen.
Well, many thanks to all of you who have spoken and shared their experiences, views. Maybe I would like to underline another dimension. Being a minority may not always be limited to ethnicity. In countries which seem to be rather homogeneous, may have many other specialties, features that may put them in a minority position, even throughout history, or at the same time. Financial status, education, belief, spiritual activities, being a Turkish citizen since the last 70 years, I have gone through all these different episodes. It has indeed been very important for sharing all these experiences our colleagues have shared, but maybe in future, we could also discuss other dimensions in these aspects as well. I just wanted to underline that. Thank you.
Thank you, absolutely. And then again, not just trying to be a man and having the last word, but then again, we can also be mindful of the intersection of this minoritized identity and how different experiences people live by the fact of being gay and Latino, or women Latina, or more intersectional minoritized or marginalized identities, which sometimes not necessarily the picture that I'm trying to paint is not necessarily one of the more minoritized identity you have, the more deficit you have, or the worse but just the differences. There might be the case where someone can draw strength from the fact that they feel the sense of belongingness, connectedness to the LGBTQ community, from where they draw a strength that allows them to navigate as an ethnic minority in a Western country, for instance. It's not necessarily always an addendum of deficit. It's complex. And yes, I fully agree that there is more to it than just ethnicity. Absolutely. Okay, being mindful of the time, I just want to say again, thank you very much to all three presenters. Dr. Eugene, Jazz, Joyce, thank you very much for your presentation. And Ramin, Idil, Bulin, to you as well for your questions and comments. And hopefully we'll see everybody again in a month from now for our 8th intergenerational meeting. Looking forward to that.
Thank you so much, everyone.